Good evening, all. I hope you can see me and you can hear me. Uh, very warm welcome to part two of our Master Techniques webinar series. This is number 12th Master Techniques webinar, BOFAS. And we have the two speakers who gave an excellent talk on malunion following ankle fractures, and we have invited them to talk about malunion following calcaneal and talus fractures. Before starting the webinar, I would just like to do a couple of housekeeping announcements. The first one is that you can put your questions through the Q&A, and after the two talks, we'll have time for discussion, and I'll present those questions to Nikos and Stefan, our guest speakers. The second announcement is that once we finish the webinar, immediately you should receive a feedback form, and once you have filled it in, then you will be awarded the certificate of attendance for the Master Techniques of BOFAS. As you know, we alternate Master Techniques with General Club. So the General Club for BOFAS is next month, and then we'll be back again in June with another episode of Master Techniques. So let me invite our first guest speakers, Nikolaos Gougoulias, a very good friend and colleague, member of the Education Committee of European Foot and Ankle Society, great educator, and likes dealing with complex reconstruction and deformity correction. So Nikos is going to talk today about how to deal with malunion following calcaneal fractures. And I'm going to hand over to him once he's ready.
Thank you, Maneesh. Honored to be invited again for this Master Technique series. And my topic today is malunion of calcaneal fractures. And those of you who are familiar with the UK heel fracture trial and that publication in the British Medical Journal about 10 years ago now, might think, why is that topic important? Do we have problems with malunion, since there is no difference in clinical outcome whether you fix calcaneal fractures or not? And actually what this study highlighted, the high infection rate with surgery. And if you look at the front page of the British Medical Journal of 10 years ago, it says surgery provides no benefits. However, it does not say that the results of treatment, whether operative or non-operative, were quite bad, and the outcome scores are about 60 to 70 out of 100, and the SF36 score of general health, I would say, is similar to that of patients with chronic illness. And actually, what this trial, which is scientifically sound, showed that whether you operate or not, these patients with calcaneal fractures do not do well. And that probably takes us 100 years back with that statement in the JBJS in a different era that said these people have serious problems. The patient with a malunited calcaneal fracture is typically this type of patient who comes and says, well, one shoe must be bigger than the other. I have instability, I have constantly pain, I'm limping, and there is impingement and on the outside of the leg. However, you have to bear in mind that a fracture like this was excluded from the heel fracture trial because that type of fracture was fixed and was excluded from the trial, as well as these fractures, which constitute an orthopedic emergency that can result in soft tissue problems, and these should be fixed as emergency surgeries. Now, and just a few words about the trial to avoid any confusion whether we need to do anything about these patients with calcaneal fractures. There was, as highlighted by other publications, a selection bias in the trial, as of 2,000 patients with calcaneal fractures and 500 were eligible, only 7.5% consented to participate. Some had treatment preference, and for some others there was a reason why they were managed operatively or non-operatively. So yes, the methodology is okay, the results are valid, but the interpretation was wrong in the way it was presented in the British Medical Journal a few years ago, and it does not say what happens to these patients who have a malunion, whether treated operatively or non-operatively in the long term, because what we know from other studies, the result of a subtalar fusion in a patient who has a normal calcaneus, so the shape is normal and the mechanics is normal, is much better than the outcome of a patient with a malunited calcaneal fracture. And remember, these fractures in the first place, when we have the acute fracture, first of all, we have a high impact injury to the cartilage and the joint, and that is likely to cause osteoarthritis in the subtalar joint. And then we have a high energy injury to the bone, and that changes the shape of the calcaneus, the shape of the whole foot, the mechanics of the foot. It causes impingement on the outside with the peroneal tendon, sometimes sural neuropathy, and rarely non-union. And this is how we assess these fractures before or after surgery with these two-dimensional radiographs, or more accurately with a 3D imaging, so with a CT scan. And what we will see when we see in the acute phase a no-scalces fracture is that the heel will go into varus or valgus. There will be loss of the calcaneum. The lateral wall is likely to be bulging on the outside. The width of the heel increases. And overall, there is a difference in the shape of this bone. So if it is left to unite in that position, it is very likely that we will get subtalar joint arthritis, impingement of the peroneal tendons, impingement of the calcaneus onto the fibula. The ankle joint will not function normally because the shape of the hindfoot and the mechanics have changed. The insertion of the Achilles tendon will be elevated, and the gastrosoleus complex will be weak. The calcaneus is generally short, and that affects the windlass mechanism. There is varus or valgus deformity, and the leg is likely to be shorter. And as I come back to that picture, the typical patient with a calcaneal fracture malunion, who has a wide heel on one side, swollen leg, painful, unstable lots of the time, and he says there is something clicking on the outside and symptoms associated with impingement and pain. And in 1996, Stevens and Sanders came with that malunion classification. Type 1 is those patients who have a lateral exostosis, so extra bone on the outside of the calcaneus, and arthritis affecting the lateral part of the subtalar joint. On some occasions, the whole of the subtalar joint is affected, and sometimes the calcaneal body is malunited, but it doesn't say a lot about any subtypes of this type 3, what sort of differences in shape we have. And then these authors reviewed some cases they operated on, and they recommended for type 1, so when there is only the lateral half of the subtalar joint affected, you don't fuse, you do exostectomy and peroneal tenolysis, which you combine with an arthrodesis if the whole of the subtalar joint is arthritic, or with a bone block arthrodesis and osteotomy if you have a malunion of the bone. And out of the many cases they treated, a fair amount was available for follow-up. And as you can see, in about 10% of patients, they did not fuse the subtalar joint, so did joint preserving surgery. 90% received the subtalar joint fusion, and the fusion rate was 93%. Now, Stefan Rammelt and Dr. Zvip came with another classification about, which is a lot more comprehensive, I could say, about 20 years ago. And they said type 1 is those fractures where the subtalar joint is incongruent, so I would say arthritic. So if you have incongruity and varus or valgus of the hindfoot, that's a type 2. And in addition, if you have loss of the height of the calcaneus, that's a type 3. And if there is any translation of the calcaneus to the lateral side. You see that bulging of the bone. It's a type 4, and when you have malalignment at the ankle joint, is a type 5. And there are various treatment options. One problem, as we said, is the peroneal tendon impingement of the sural neuropathy. If there is metalwork from previous surgery, you can remove it. You can do an exostectomy of that extra bone on the outside, debridement and repair of the degenerated peroneal tendons, and sometimes sural neurectomy. If there is stiffness, malalignment, and arthritis, then you have to choose between joint preserving surgery versus arthrodesis. And for joint preservation, if you have, let's say, one part of the subtalar joint affected, you consider an osteotomy or debridement of the scar tissue within the subtalar joint, possibly arthroscopic, or you go on to an arthrodesis, and then you have to decide whether you do an in situ arthrodesis, or whether you want to destruct the, I would say, the hindfoot using a bone block, and whether you have to add an osteotomy to correct varus or valgus. And do not forget that with all these operations, you may have to lengthen the gastrocnemius or the Achilles tendon. Now, how do we decide whether we fuse the subtalar joint or not? Let's say selective injections. Are they really selective? Is that accurate? I would say, because there is spread in the surrounding joints, probably best to use a SPECT CT scan to see where the pain is coming from, see which parts of the hindfoot are really hot on the scan. Let's look at this case. A patient has had a minimally invasive surgery for fixation of a calcaneal fracture, and there is some lateral hindfoot pain localized in the sinus tarsi region. We do our workout with the CT scan. We see a little loose body, possibly a screw causing the problem, and some irregularity of the incongruity of the subtalar joint. One has to decide whether, depending on the symptoms, I would say, mainly whether that joint can be preserved by just removing some extra bone, removing the screw, or removing the scar tissue from the sinus tarsi. I wouldn't say there is any strong evidence to recommend that this is a really successful operation, but it can be considered an option for some patients, especially if you're not convinced that there is really arthritic, a really arthritic joint causing the pain, and there are some minor impingement symptoms. Different patient with calcaneal fracture in the past, both medial and lateral hindfoot pain across the subtalar joint. There are no metal implants, as you can see, that was treated conservatively, and one can see that there is some irregularity of the subtalar joint without any obvious malunion of the calcaneum. The subtalar joint is clearly arthritic, whereas the calcaneal bone joint is normal. In a case like this, one can consider an in situ arthrodesis, whether you do it arthroscopically, which is an option for in situ arthrodesis, or open, it doesn't matter, and that can solve the problem. That was a type 1, I would say. A type 2 is the arthritic joint with varus or valgus malunion, which again you may be able to correct through the joint, and even this procedure can be done arthroscopically if you are experienced enough, if you are able to correct I would say minor varus or valgus through the joint without any major additional procedures. As you can see in this case, there is arthritis, there is valgus alignment, but there is also a loss of height of the calcaneum. I don't think you can treat it arthroscopically because you may want to distract that hindfoot and to get rid of the loss of height, so to increase the height of the hindfoot by inserting a bone block, and that can only be done through an open procedure to improve not only the pain but also the overall mechanics of the hindfoot, so perform a destruction arthrodesis. The case I showed you, I think, at the beginning with a patient who is a smoker has had quite only 9 months before a calcaneal fracture in very bad pain. He's limping and he feels his hindfoot is unstable. Something needs to be done about it. And unfortunately, this fracture was left untreated. Even if he is a smoker, that could be reduced quite easily, even with minimally invasive surgery. And he's a young patient with devastating pain, a wide heel, but without any clinically obvious varus or valgus deformity of the hindfoot. And in this case, and bearing in mind he is a smoker, so maybe high-risk patient for complications with major surgery, a sinus tarsi approach is probably preferable. And what I did here is I removed the bone from the lateral aspect of the calcaneum, used it as bone graft to do a bit of a destruction. You see that I go one slide back on the picture on the upper right. You see the FHL tendon on the medial side, and you destruct the joint, you put the bone graft in there, and you fix it the usual way. I use 3 screws here because I was a bit worried about the patient being a smoker. Or in other occasions where there is a significant varus or valgus alignment, what we call a type 4 according to Stefan and Rammelt, then you have to add the calcaneal osteotomy, medializing or lateralizing, depending on the deformity. And in a little bit more detail. In this case, again, young patient, calcaneal fracture 1 year before, treated non-operatively, in a lot of pain, lateral wall bulging and valgus alignment significantly on the heel. And so I decided to go for a major operative reconstruction here with calcaneal osteotomy through the same L-shaped incision, prepare the subtalar joint. You see the translation, the varization of the heel. There we remove that extra bone from the outside, nice cancellous bone, which you can use as bone block to put it into the subtalar joint and do your destruction arthrodesis as well. So osteotomy to correct varus or valgus, take the extra bone from the outside to destruct the hindfoot and do subtalar arthrodesis. Now, as I said before, do I always have to fuse? There is not much in the literature. Again, these authors from China show that only in 10 out of 127 cases they attempted joint preserving surgery. It depends really how bad the subtalar joint looks on the imaging. Again, if you do joint preserving surgery, they recommend it. You remove the lateral, you do an exostectomy and a V-shaped osteotomy to change the mechanics of the hindfoot without fusing the subtalar joint, like in this case, correcting varus or valgus if needed. But I would say in the vast majority of cases, you have to do a subtalar joint arthrodesis because the subtalar joint is affected in the vast majority, I would say in 90% of the cases, according to the literature, and that's my experience as well. So if you attempt joint preserving surgery in some minor in cases with minor arthritis, you have to remove metal, do an arthroscopy, lateral exostectomy, plus minus osteotomy if there is varus or valgus. And if you do an arthrodesis, you have to decide, do I do an in situ arthrodesis, or do I do a corrective arthrodesis if the shape of the calcaneal body is affected, if there is loss of height, if there is significant varus or valgus. So what do I do? When I see a patient, is the pain coming from the joint or not? So that I do a clinical examination to see if there is just localized pain in the sinus tarsi or whether there is pain both in the medial and lateral aspects or across the subtalar joint. And I do my MRI, possibly SPECT/CT scan, and maybe a guided injection, although I'm not convinced that helps a lot. Then, is the joint stiff? If the subtalar joint is stiff, even if there is no significant arthritis, I have a patient with a hindfoot that is stiff and painful. I can make it pain-free and stiff. So I think it's probably best to do an arthrodesis it's safer, I would say, because you do one operation, not to worry that the patient will develop subtalar joint problems at the later stage. And then if there is varus or valgus, significant varus or valgus, how much is significant? I don't have the answer. The literature doesn't have the answer. You are the calcaneal osteotomy, medializing or lateralizing calcaneal osteotomy. And if there is a lot of height, loss of height, you do a bone block destruction, arthrodesis most of the time. So the take-home message, I think calcaneal fractures malunion is a big problem. And the best way to manage this is to try and avoid by doing surgery in the appropriate patient in the first place. And I would say with the techniques that are available these days with MIS surgery and the sinus tarsi approach that is associated with a lot less risk of infection, any patient is suitable for primary surgery if his calcaneus fracture looks bad enough. And it is a big problem because it does not only, the calcaneal fractures do not only cause arthritis, but also change in the shape of the calcaneus that causes all the problems. Thank you for your attendance.
Nico, that was brilliant. Really, really good talk, take home messages, and I'm sure there will be some questions which we'll discuss afterwards. So let's move on now. And the second talk of this session, we are privileged to have Professor Stefan Rammelt with us, who I would say is a master of malunion of ankle and hindfoot. He has done a lot of publications. As you have seen, Nikos has used this classification. Stefan is a professor of foot and ankle surgery and the head of the University Hospital in Dresden. He's also a visiting professor in Charles University in Prague and is the vice president of the German Foot and Ankle Society. So, Stefan, thank you so much for coming and speaking to us on the malunion of ankle and hindfoot. So, please educate us about the malunion of talus fractures. Thank you.
Thank you very much, and thank you for the kind invitation. I hope you can see.
Yes, we can see
the full screen. Yeah. This is the little town I come from, a little smaller than London, but a lot of foot injuries, a lot of construction, and a lot of hiking in the regions around. And unfortunately, also we see a lot of malunions following talar fractures. The talus is a bone that you usually don't want to break because it is all trouble. It is surrounded by joints, by essential joints for the foot function. And even if there is a fracture that is outside the joint, a classical talar neck fracture, even then, if it's malaligned, then automatically we have significant pressure redistribution through the adjacent joints, and we will have trouble down the line, and automatically we will have a three-dimensional foot deformity. If you watch talus fractures long enough, no matter if they are treated well or not, the post-traumatic arthrosis rates will go at some point, maybe at 10 years, maybe at 20 years, to 100%. That doesn't mean they will all be symptomatic or require secondary fusion. This is about 20-30%, but it's a significant number. And the non-unions typically arise from technical problems or from patients that have not been treated operatively. Avascular necrosis is a common problem after talar fractures, and we have to distinguish between necrosis that leads to a collapse, like in that case shown here, and necrosis that will automatically appear if you do an MRI scan a few weeks after a talar body fracture. The blood supply through the talar neck will be disrupted in any displaced fracture, so there will be some kind of necrosis in parts of the talar body, which will not be clinically significant. And then, of course, we will have a whole bunch of soft tissue problems around the talus if there is a malunion. So Professor Zwipp, who was my mentor, and we tried to do a simple classification also of the talar malunions. Sorry for the missing S. And so type 1 is a malunion. So at some part of the joint or of the body, there is a malunion, but it's solid. Type 2 is a non-union, and type 3 is any of those with a partial necrosis of the talar body that does not lead to a collapse. Typically, that is about 1/4, 1/3 of the talar body. Type 4 is a total necrosis of the talar body with collapse or with impeding collapse, and type 5 is a septic necrosis, so additional infection, which of course is the worst thing that can happen. So let's start with a simple one. This is the classical malalignment of the talar neck, the so-called C-foot. In this case, obviously the C-foot is a bit more pronounced because we have some metatarsal fractures that are malunited. You can see the callus here, so it is all already kind of solid. But there is also a significant deformity in the hindfoot, as you can see from the clinical image. So this was a polytrauma patient. Everything up to the level of the ankle joint was treated nicely. And then at the talus, the diligence stopped, and just a K-wire was run through, or 2 K-wires, one obviously dislocated. And this is the position of the talar neck, which is a significant varus malalignment of about 30 degrees. The joints are fine so far. They are in a bad position, particularly the talar-navicular joint. And you can see on the medial side, there is that typical zone of comminution, which leads to a varus malalignment in the majority of cases where there is a malalignment at the talar neck. So what to do? Extra-articular deformity, we can do an extra-articular osteotomy. And there was the fear that if you do an osteotomy of the talus, this might disturb the blood supply. But if the initial fracture did not lead to a full necrosis of the talar body, and you go with the osteotomy exactly along the same lines, and you are careful with the soft tissues and with the blood supply, then no necrosis will appear. So here you can see the bone block of almost 1 centimeter was brought in from the medial side. This is the patient 1 year later. You can see there is still some change in the radiolucency of the talar dome, but the talus holds, and the patient has a well-aligned foot. And we didn't care about the metatarsals, which healed nicely with that axial malunion, but as long as they don't have a sagittal malunion, obviously this is very well tolerated by the body. This patient now is 10 years out. He has some arthritis, but still walks around with all the joints there. Now this is a malalignment of the posterior body, and a nice example why it is also good to know the anatomy of accessory bones. This patient was treated in that torture machine here, like a Spanish boot in the Inquisition, because he was suspected to have an ankle sprain. And even with patients that only have an ankle sprain, we don't do this anymore. Here it was tested. The ankle was stable, of course, because the fracture was in the talus, and the patient was diagnosed to have an ostrigonum. But this looks quite big for an ostrigonum, and the patient also had a significant pain and an adequate trauma. 7 weeks later, someone did a CT scan because he had continuing pain, even though he had quite some physical therapy. You see that multifragmentary fracture of the posterior talar body. You can see that the intermediate fragment is already firmly healed to the talar body. The posterior fragment, because it's dislocated, has not healed. So at this point in time, we needed to do a formal osteotomy of that intermediate fragment and just the debridement of the posterior fragment. And then with the help of a distraction device, of the femoral distractor, we could see into both the talar, the tibio-talar and the talar calcaneal joints to make sure that there is anatomic reconstruction of the talar body. And this is now the patient with the healed fracture, and he is going on to full weight bearing. This is a very interesting case. This was a young waiter. He fell on stairs. He did not walk for quite some time, didn't work. And he came 3 months later because he still had pain. And then this obviously non-displaced fracture that was not recognized initially now started displacing. And these are the x-rays 4 months later. Here you can see, and also in the CT scan, you can see the large step off of about 4 millimeters in both the ankle and subtalar joint. The patient had relatively mild symptoms, but we said to him, okay, if we don't do something now, he will go on straight to ankle and subtalar arthritis and then a complete hindfoot fusion. So we went there at a little less than 5 months, and we did an osteotomy. You could nicely see the former fracture line and enter with the osteotome, and then go all the way through to the subtalar joint. The reduction of the subtalar joint was controlled arthroscopically because it was not nicely seen from the margin, and then the fracture was fixed with screws. We put some bone graft onto the talar neck in that region where there was already a mild cyst, and the screws in the medial malleus are just from the osteotomy. So here you see the pre-op and post-op CT scan. You see the reduction. You see the filling of that small defect with bone graft from distal tibia. Here are the axial and coronal CT scans. So this is the patient 2.5 years later. At that point in time, he didn't have any secondary arthritis. Of course, if we follow him long enough, we will see it. At that time, he had a almost free function of both the ankle and subtalar joints. So the effort was worth it in that case. This is a really sad case. This young lady was not put into that torture machine. The doctor decided to torture her by himself to make sure that the ankle is stable. Of course, the ankle was stable, but it remains ridiculous why this fracture, dislocation of the talar body with the complete dislocation in the subtalar joint and the subluxation in the ankle joint has not been seen. Finally, 2 weeks later, someone saw the fracture and decided to do some fancy thing, minimally invasive or percutaneous surgery of the talar neck fracture from behind, because there's one study from the 80s that pretends to show that screws from behind are stronger than screws from the front. But the bad thing was the fracture wasn't reduced. So the patient had still that large step off in the ankle joint, so ankle motion was restricted, and the subtalar joint was still completely displaced. She was walking with that kind of boot. She was unable to bear weight and was miserable at that time. And when we went back, we could save the ankle joint, but at that time, the subtalar joint was already gone. So the only thing to do was a subtalar fusion, which is not the best solution in a 16 or then 17-year-old girl. Nevertheless, she had a straight alignment. Here you can see that huge step in the ankle joint. She had a straight alignment and a good function of the ankle joint at almost 2 years later, but subtalar motion, of course, was restricted forever. Here's an interesting case. A medical doctor from internal medicine presents 3.5 years after bicycle accident, continuous pain, not much to be seen, a little arthritis in the x-ray, and in the CT scan, you can see a non-union at the talar neck with very little displacement. So we went there. It was Hans Zwipp's case. He went there, debrided it, and put bone graft inside. And because he was a medical doctor, he was very interested in healing and particularly worried about avascular necrosis. So he kept sending us MRI scans, which showed that everything was in place and everything was fine. So this is him 2.5 years later. The arthritis of the ankle has not gone, but on the other hand, it hasn't progressed at that time, and there was no sign of avascular necrosis. Here we can see a patient that was completely neglected with a displaced fracture. You can see the step off again in the ankle and subtalar joint. At 7 months, he was corrected via osteotomy. He presented 2 years later with osteophytes, so with anterior ankle arthritis. We removed the screws and did some chilectomy from the front. And he came back 14 years later, so 12 years after that second surgery. No pain. The only thing that bothered him was that he couldn't get his foot beyond neutral. So despite the arthritis that was clearly seen here, he just wanted another osteophyte removal, which we did. He's now about 20 years out or more. And this is the very first case that was done by Hans Zwipp when he came to Dresden in the 1990s. A young male, motor vehicle accident. This obvious dislocation was reduced immediately, but then the second step was missing. So 6 months later, he presented with that type of malunion. And again, you can see the dislocation in the subtalar joint and the incongruity in the ankle joint. And you can also see in this patient that there is less radiolucency in the talar body. So there's at least partial avascular necrosis. Still, after medial malleolar osteotomy, the talar dome looked fine. There was still some cartilage there. The patient hadn't put on too much weight. So he was treated with an osteotomy along the former fracture line and secondary screw fixation. This is 3 years later. You can see the talar body at the top still looks a bit weird. So there might be some necrosis at the top there, but no collapse, so a partial necrosis. And this is the patient almost 22 years later after reconstruction. Someone ventured to take the screws out, which is not fun in the talus. He came beyond neutral, so he didn't want an osteophyte resection. He was just doing fine at that point with his ankle more than 21 years after reconstruction. Now we are coming to the worst types. This was a lady, heavy lady with a comminuted talar body fracture. I treated her with open reduction, internal fixation. I was very proud of my reduction, but then the talar started collapsing. Still, at that time, the shape of the talar dome was more or less preserved. 2 screws were broken. There was a little bit of giving away of the talus. And so at that point in time, we teamed up with our vascular surgeons. We tried to lift up that portion that started coming down. And our colleagues from vascular and plastic surgery did free femoral condyle, vascularized and put it in, which we just then fixed with a screw. And this is the lady 9 months later with a reasonable function. Still, the ankle holds. We will see how it evolves over the long term. This is her, the x-rays, underweight bearing 6 months later. But this is a very rare exception. Typically, when patients present, they come like that. So 10 months after open reduction, internal fixation, there is a collapse of the talar body. The cartilage is gone. The ankle joint is not salvageable. And in this case, also the subtalar joint was not salvageable. So this patient got a hindfoot fusion with a retrograde nail. Still, she was doing okay. But of course, the functional result of these surgeries is not so exciting. And this is the worst case. A very young patient. He was run over by a small gauge railway, had several radical debridements. Still, he developed osteomyelitis, so he needed serial debridements, was put in a frame, and PMMA beads with gentamicin were put in to fight the infection. And then finally, when the infection resolved, he was subjected to tibio-talar calcaneal fusions, which a large chunk of bone grafting after that masculate type osteogenesis. And you can see it healed in a nice position, although with a very stiff hindfoot. The patient, because he was young, could adapt to it. He could walk 2 to 3 kilometers with a heel lift. So still the hindfoot could be saved, but with a whole lot of loss of function. And this is probably the worst case we see in a very rare case of aviators astragalus, where there was a comminuted fracture of the talus, but also a fracture of the calcaneus and of the medial lateral malleolus. So it was a floating talus, an open injury. We tried to save the day with the early fusion of the ankle and subtalar joints, but still he developed septic AVN. So the remainder of the talar body had to be thrown out too. The flap had to be advanced. Again, we started with the Mascalet technique, and then as a salvage procedure, he was put in an Elizarov frame and got a tibial-calcaneal compression arthrodesis, so kind of a resection arthroplasty at the former Chopin joint. Interestingly, he was doing quite okay. He was not having pain during daily life, but of course the hindfoot with the loss of the talus was much shorter. But because he underwent more than 20 surgeries, because he was a polytraumatized patient, he didn't want to have any surgery anymore and walked around with a heel lift. So these are our results after anatomic reconstruction, so joint preserving procedures, and they are echoed meanwhile by some other colleagues who did the same things. The most important thing is if you do an osteotomy along a former fracture of the talus and you take care of the soft tissues and the blood supply, then there's no progression of necrosis. So those patients type 1 and 2 without necrosis, they didn't develop necrosis, and those of type 3 with the partial necrosis didn't progress with necrosis. That's very important. We saw progression of the arthritis in 8 cases, so roughly 1/3 of the cases, which probably you can also see in a talus fracture, which is nicely aligned from the beginning. Secondary fusion needed to be done so far in 3 cases. Satisfaction was high, the function was much improved, which is also due to the severe loss of function after malunited talar fracture. And the results were slightly better in patients who had non-operative management initially, which appears logical because if you do surgery, you have the worst of both worlds if you don't manage anatomic reconstruction. So you have the risks of surgery, the soft tissue damage, and in addition, you have the malunion in those patients. Some more salvage options if there's a total AVN or bone loss after septic necrosis, or if the talus is just left on the street. You can go on in severely ill patients, in diabetic patients sometimes, to really go with astragalectomy, leave the talus out. Particularly, this is might be done in patients after severe infection. Sometimes you can leave the PMA spacer in younger patients and patients with a bit more of functional demands. Custom talar body prosthesis can be put in, like in that example, or talar body prosthesis that's combined with the total ankle. I personally don't have much experience with this variant. Of course, pan-talar fusion is the last exit and leads to a very stiff foot, almost like a wooden leg. So to sum up, it is, of course, always good to try to save as much joint function as possible after talar malunions, which is not always possible. You have to go early because it is not possible if there's already symptomatic arthritis. It is also not advisable in patients with poor compliance because they don't benefit from joint preserving procedures, and also if they don't comply with your post-op regimen, then probably they end up worse than they started. And in patients with a complete necrosis, in very few select cases, you might save the day or maybe save the patient some years with a free vascular graft. Otherwise, corrective fusion or a total talar prosthesis, and to save the affected joints is the treatment of choice. And with this message, I want to conclude. Thank you very much for your kind attention.
Thank you, Stefan. That was absolutely fantastic. So many cases you have shown and the wealth of experience you brought in is so invaluable. We have a few questions from our listeners. I will start with their questions first. So, Stefan, there's a question asking, what do you do with complete extrusion of the talus? Do we put it back after cleaning or bin it? I think you've tried to answer.
Absolutely, yes. There was a nice. I think the person asking is from India. There was a nice study by Mandeep Dhillon and his colleagues of total talar dislocations. Sometimes the talus is still in, sometimes it's out. It's always worth putting it in because there's nothing like the original talus. And my former chief always used to say, even if the dog brings it on in his mouth, he would clean it and put it back. You can still fuse it. You can maybe use part of its own talus as a bone graft, but there's nothing better than the patient's own talus. And the results from the literature are quite amazing. Of course, there are more positive cases reported than negative cases because it's always exciting if you put a talus in that is completely denuded from all soft tissues, from all blood supply, and still heals. So I guess there is some bias towards positive case reports, but there's a lot of literature that it's worth the effort. Of course, there might be necrosis. Of course, there might be arthritis, but this can happen to any talar fracture.
Thank you. So, Stefan, just to expand on that, and you obviously you've said that you don't have much experience with the replacement of the talus, but do you think it as evolving with more trauma and more new techniques coming in, and where is the line where you say, okay, this talus has gone beyond fixation, or you say every talus needs to be fixed before considering replacement?
I would still fix it because it is the patient's own talus. And I would consider a primary fusion if the joint cartilage is gone completely and still the patient has his own bone stock. Because what you do with the total talar prosthesis is it's a hemiarthroplasty on 3 joints. So it is a matter of time that this will fail. And if you look at the long-term results, I think there are groups from Japan, from Thailand, about 30 to 50% of them fail in the long term. And also, this is only an option if the tibial plafond, if the surface of the calcaneus, the subtalar joint, is still intact. If this is also damaged by the energy of the fracture, then of course the talar body prosthesis won't hold too. But I think it's an evolving field. Probably with the new generation ceramic prostheses that are out now, it might work better. But we have to wait for the long-term results, and I will definitely watch that closely. And I also have now 2 patients in line who we consider doing this, but we have to tell them it's still a bit of experimental surgery. Probably buying young patients some time. We have to wait for the long-term results.
Thank you. Now, one question has repeatedly appeared in the chat, and I'm going to ask you both. Maybe it's different with talus and calcaneum. So when is it too late to operate? So we're talking about a malunited scenario, and we're talking about whether we can fix it or we have to go for fusion. And does it vary with talus and calcaneum? So I will ask Nikos first, and then Stefan, you can answer that from talus perspective.
So, well, I assume the question is if you have a calcaneal fracture, which is in the acute phase, when would you consider fixing it? Let's say somebody else hasn't fixed it. I have fixed a calcaneal fracture that was 4 weeks old and achieved a quite good reduction. So it was quite bad. So I decided I will not leave the patient untreated because that would end up into a malunion. If it was 6 weeks, it would have united. If it is a bad situation, like some of the cases I showed, like the patient who was 9 months, he wasn't too long down the line from the acute phase. I would still attempt it at 6 weeks. because then you consider it as a malunion if the calcaneus has really united, and then you go back to the options, which type is that, and do you do an arthrodesis or not. But I think in the vast majority of patients are 4 weeks, the fracture, it's difficult, but it has not fully united. And I think I'm amazed by Stefan's results, and I'll ask him now. He will answer this question. I will also ask him. I'm amazed that, like you were proud of fixing so nicely a talus fracture. I had exactly a similar fracture that ended up in AVN a bit later, but the patient was a smoker. Do you think it's the type of the fracture or the anatomy that was disrupted, or is it the patient that causes the AVN up to 18 months down the line, where you're initially, my experience was that the fracture has united, confirmed with CT scan, very good outcome, and then collapse at 18 months. So, and on the other hand, you fix some malunions later and you don't get necrosis. What do you think is important? Why do some patients do well and others do not?
So first, I would start with Manish's question. So it is too late if there is symptomatic arthritis or if the cartilage is gone, which can be, in the worst case, at the time of the initial trauma, or it can happen very quickly, particularly at the subtalar joint. So my experience is the same as Nikos in calcaneal malunions. If the patients walked around on their malunited calcaneus, on the malunited subtalar joint for a couple of weeks, then typically because of these shearing forces, the joint will be gone. The ankle can take a bit more, and also the talonavicular joint. So that is why in talus fractures, we do more corrective, even intra-articular corrective osteotomies than after calcaneal fractures. And so the time for fixation, it is never too late. But of course, if there's already arthritis, then you have to consider a primary fusion or an early secondary fusion if those patients present late. And I have fixed calcaneal fractures also after 6 weeks, after 8 weeks. If the patients didn't walk around on them, if they were injured in another country, they were lying in bed, or they were polytraumatized, and then finally they came to see me. If they didn't walk around, if they stayed in bed or walked on crutches, then there is a chance that the cartilage is still there, that the joints will still be fine, and then you can do your osteotomy along the former fracture. And now to Nikos' question. Of course, the cases I showed, which are amenable for secondary correction, are relatively simple intra or extra-articular fracture. If it's a comminuted fracture, like the one that I showed with multiple fragments of the talar dome, then you're happy to put them together the first time. You still have to keep your fingers crossed that there's no necrosis. But these cases, if they malunite, I think nobody would have the idea to take this apart and put it back together. So the non-unions that we really treat, you see the number of cases that we collected over more than 10 years. These are 20 cases, 25 cases. We did more than twice as much fusions for malunions that had arthritis in either of the joints.
Thank you. Thank you very much. I think that's very clear about the different fractures and obviously the difference in talus and calcaneum and patient walking or not. The other question, which is, we can't control sometimes, and, you have alluded in your talk, Nikos did, and so on. I mean, what do you do if somebody presents with a malunion, difficult problem, and patient has got issues, they can't stop smoking? What do you do? I mean, we know smoking is an adverse feature in the healing. And if you do a complex reconstruction, do you do it, or what's your approach?
I would say there must be a reason why the patient was not treated operatively in the first place. And usually these patients are likely to be smokers or have other comorbidities. Now, then there is not one approach. Theoretically, you have to do a complex reconstruction, osteotomy, bone block arthrodesis. Sometimes you have to play safe first. And if you have a patient who is high risk to develop a complication like a diabetic, or a heavy smoker or an alcoholic or a low demand patient, I would say, then you may have to consider a more simple in situ arthrodesis, knowing that they biomechanically the hindfoot will not be sound, but to get rid of the pain. But even then, if you have to do an open procedure, then you may have to do a sinus tarsi approach, still do an exostectomy because the lateral wall is bulging, impinging on the peroneal tendons, and lots of the problems are coming from that side. So the sinus tarsi approach is a relatively safe approach not to have a serious wound infection like with the extensile lateral approach which I use for more complex reconstruction. So yes, you have to consider who is your patient and whether they will benefit from the surgery. And sometimes you have to avoid doing surgery because is this patient going to be better after an arthrodesis, after an operation, or is this patient not going to benefit from that because it's the wrong patient to do surgery? So consider doing nothing with some patients.
Thank you, Nikos. What do you think, Professor?
I think exactly the same. So there are patients who smoke, of course, and an acute fracture, I don't ask. I tell them maybe it's a good time to quit smoking because you can't smoke in a hospital and you just don't resume when you come home. If they present for a complex reconstruction, I try to be very adamant to tell them the complications. I always tell them your foot can be turning black even without surgery when you smoke. Now I take it apart. You don't want that. I don't want that. And particularly if you plan a fusion or an osteotomy, smoking is a significant risk factor for non-union. And if you do a fusion, have a non-union, the patient will have the same pain as before, plus the risks of surgery. So I would really demand they quit smoking. Some do it. Some of them resume after the reconstruction has healed. Some don't. And there are some patients, they still appear reasonable. They say, doctor, I tried everything. I'm down from a pack to 5 cigarettes per day. Then you have to really make up your mind. You have to see if the patient is otherwise reliable. And so I would not close the door in front of them.
Thank you. Thank you very much, both of you. There's another question from audience about the role of lateral malleolar osteotomy for malunited lateral talar body fractures, Stefan.
You need it less frequently, only if there's really a posterolateral lesion, most of the time osteochondral lesion. Then I do a simple Weber type B fracture, so an oblique osteotomy. Some do a 3-part osteotomy to hook off the syndesmosis and bring it back, the insertion on the fibula. I just do a simple Weber B fracture, an oblique one, that aims at the apex of the lateral talar dome. I put the screws for the plate in for fixation before that. So then the fixation will be anatomically and will be quickly at the end of the surgery.
Thank you. Thank you. A question for both of you, a very general question about talus and calcaneal fractures malunion. Talking about bone graft, what is your preferred bone graft option? Nikos and then Stefan, where do you take the bone graft from? I know you've talked about the extruded lateral wall, but is that what you do or you do something else as well?
Yes, in the complex cases, bone graft. If it's an in situ or a primary arthrodesis, I don't use bone graft if I don't have to change the shape of the calcaneus. If there is a non-union, it's different, of course, because you have to enhance the capacity of the bone to heal, and you may use iliac crest bone graft or any orthobiologics. But let's talk about the malunited calcaneal fractures. Especially if you do an osteotomy, there is quite significant amount of bone on the calcaneus, which I use. I can't to remember that I have used the other option is iliac crest bone graft for a subtalar fusion if you need to distract a lot.
Thank you,
I
Nikos.
typically use iliac crest bone graft either as cancellous bone, so I just open a window, get some bone out, or as a tricortical bone blocks in a subtalar correction fusion. So I prefer that over a xenogenic bone graft because it has all the growth factors which you would otherwise have to buy for a lot of money. And in my experience, I see all my patients with complex reconstructions at 8 weeks or 12 weeks after surgery, and virtually none of them has relevant symptoms at the donor site. So it's quite often cited that a lot of patients have symptoms there. I still have to see them. If you do it in a nice technique, in the slim patients, there might be a dimple, there might be a scar. So this might be a cosmetic issue, but otherwise, for me, that's the preferred source of bone graft. In avascular necrosis, I would consider a vascular bone graft and would team up with the plastic surgeons for that. And if there's really a huge defect, then you have to think about other solutions like a talar body prosthesis or a femoral head or a cage, a tantalum cage, porous cage, something like that.
Thank you very much.
If you do a tibiotalar arthrodesis or tibiocalcaneal arthrodesis after complete talus extrusion or AVN, do you ever use the fibula?
Sometimes, yes. And I typically, if I use it as a strut graft. So I leave it in the soft tissues, in the posterior soft tissues, and I just debride the formos syndesmosis. I debride the remainder of the talus if it's still there, and then I bring it as a strut graft from the side, and then it enhances the whole construct.
Thank you.
Also a very good option is Blair fusion to shift the anterior front of the tibia down into the talus. That's also a good option, provides more stability.
Oh, thank you very much. You answered that because somebody actually asked about your views on Blair fusion. So you've answered that. Thank you. There's one more question for you, Nikos, about calcaneal fractures, and I'm just going to read it out to you. So calcaneal fracture that initially has been fixed with extensile approach, what's your incision and approach for later subtalar joint fusion? And they've said that they experience skin issues with sinus tarsi approach. Do you still recommend posterolateral approach like the one you use for distraction subtalar arthrodesis in cases that no bone block and distraction is required?
Well, yes, if there is previous surgery with a lateral extensile approach, I assume they had a plate was used. That's why they did an extensile approach. So the plate has to come out. And usually, because this is part of the problem sometimes, and there is still malunion on the lateral side. Actually, I've seen quite some bad surgeries with a plate and no reduction of the fracture. So you have to use the same approach, I'm afraid, which is quite, invasive. I have not seen significant problems with the sinus tarsi approach if there was no previous fracture. And I do not use a posterolateral approach for an isolated subtalar fusion. The sinus tarsi approach is suitable, again, to take the lateral wall of the calcaneus. Again, it depends on the personality of each fracture. So as I showed you before, one case, there was no metalwork, but I decided I had to do an osteotomy, do a major bone block destruction. So I did it through an extensile lateral approach in a patient who was young and a non-smoker. So yes, previous surgery indicates probably the approach which you have to use.
A bailout would be to do it in 2 steps. So if there's a large approach, and you really need a lot of correction, then it might be a good option to take the blade out, debride the lateral wall, maybe save the bone in the fridge, and then come back later, 4 weeks, 6 weeks later, and then only use the vertical part of the extensile approach, which is exactly the posterolateral approach, and then come from the back, and then you can lift up the heel as much as you want without having to fear any problems with wound healing. So I do this sometimes for severe deformities that have an extensile lateral approach with the plate still in.
Thank you. That's brilliant. Stefan, one more question to you. We talked about all the talus fractures, but what about the lateral process fractures that have been initially missed? Sometimes we see them quite often, they are missed. So what's your approach how long you are happy to go ahead and fix them, or if it's too late, what do you do?
I would never fix them secondarily. We know that we can take out a lot from the lateral process, a centimeter or even more, without risking subtalar instability. And there is always considerable damage to the joint from that shearing force that produces. It's typically a subtalar dislocation mechanism. So if patients have symptoms after lateral process fractures, I take it out. And if it's too much, if it's not a lateral process, if it's the lateral body and there's arthritis, then unfortunately, you have to fuse the subtalar joint. But there is, in my hands, there's not much role for a secondary fixation of a lateral process fracture. Take it out.
Thank you. Nikos, same question to you. What about the anterolateral calcaneal fractures if they are missed? You just take them out, or what do you do?
Maybe we should make a comment for probably the younger members in the audience. Do not miss fractures. It's not everything is an ankle sprain. If you see ecchymosis and swelling, especially if the foot looks a bit varus, it can be a talus fracture, and I have seen in hospitals both in the UK and in Greece talus fractures being missed initially, and then you end up with these complications Stefan showed us. So do not miss this fracture. Well, the anterior calcaneal process fracture, again, you would not miss it if you examine the patient on presentation. It's not everything is a lateral malleolus or a possible lateral malleolus fracture or a sprain. See where the pain is. If it's in the anterior process of the calcaneus, there might be fracture. They request for appropriate imaging, even CT scan. Yes, I would say if it's a large fragment, I would consider fixing it acutely, or then if they present late, or I tell the patient if we do not fix it, we leave it, and if it's symptomatic 3 months down the line, I remove it. I rarely had to go back and remove this fracture. So usually, if you treated the patient in a boot, so not let them diagnose the fracture, usually they will heal or cause some fibrous tissue and will not be a huge issue. But if it's a big fragment, fix it or leave it and remove it. I would say generally the same approach as Stefan about the lateral talar approach.
Wonderful. Thank you, gentlemen. You have been absolutely fantastic. You have given really key messages, and I'm sure that the practice of foot and ankle surgery or trauma will improve after the messages you have given, the key pearls. So thank you so much on behalf of BOFAS to both of you for giving your precious time, being with us, and dealing with malunion of ankle, talus, and calcaneal fractures. And audience, thank you so much for joining and asking a lot of questions. And we will see you again soon in another round of Master Techniques. Thank you and have a good night.
Good night. Thank you for the invitation.
Thank you, Maneesh. Thank you all. Bye-bye.